Welcome. In this session, we are going to talk about the opportunistic ocular infections in HIV/AIDS. And ocular manifestations of HIV/AIDS can be of three types. We can have HIV retinopathy, opportunistic infections, and neoplasms. HIV retinopathy is the most common ocular manifestation of HIV, and cotton wool spots of HIV retinopathy are the most common sign. Microaneurysms and hemorrhages can also occur in HIV retinopathy. Opportunistic infections in HIV/AIDS are numerous, and there can be simultaneous infection with multiple organisms in a single eye. Ocular neoplasms can occur in HIV/AIDS such as squamous cell carcinoma of conjunctiva, Kaposi sarcoma of the eyelid and conjunctiva, and lymphoma. We will be talking about HIV retinopathy and neoplasms in their respective sections. Later on, we will be discussing opportunistic infections of the eye in HIV/AIDS in this session. CMV retinitis, acute retinal necrosis, posterior outer retinal necrosis, and tuberculosis we have discussed in the previous sessions. CMV retinitis is the most common ocular opportunistic infection in HIV/AIDS and is characterized by retinitis with overlying retinal hemorrhages, the classic pizza pie appearance of CMV retinitis. Acute retinal necrosis can occur in immunosuppressed patients, and posterior outer retinal necrosis typically occurs in immunosuppressed patients. Tubercular uveitis in immunosuppressed patients is typically disseminated choroiditis with numerous small choroidal tubercles, sometimes in hundreds. In contrast to immunocompetent patients, immunosuppressed patients with toxoplasmosis retinitis have larger lesions which can be multifocal and or bilateral. Vitritis is less severe, older scars are less common, and they inevitably progress if not treated. In immunocompetent patients, toxoplasmosis retinitis is self-resolving, albeit with a scar formation. And in immunosuppressed patients, ocular toxoplasmosis is usually associated with CNS involvement, which increases the morbidity and mortality. In contrast to immunocompetent patients, syphilitic involvement of the posterior segment in immunosuppressed patients is typically a posterior placoid chorioretinitis, which we have discussed in the session on syphilitic uveitis. And these placoid lesions have retinal precipitates lying superficial to them, which appear discrete and creamy yellow. Syphilitic uveitis in immunosuppressed patients may present only with vitritis without chorioretinitis. Pneumocystis and Cryptococcus produce multifocal choroiditis with minimal vitritis, and pneumocystis infection is treated with intravenous trimethoprim, sulfamethoxazole, or intravenous pentamidine. Ocular cryptococcal infection in HIV/AIDS patient also presents with multifocal choroiditis like pneumocystis, and with an associated CNS infection, papilledema may occur with secondary optic atrophy, or there can be direct involvement of the optic nerve. Treatment of cryptococcosis is with amphotericin B or flucytosine. Atypical mycobacterial infection or non-tuberculous mycobacterial infection in immunosuppressed patients can present with multifocal choroiditis, anterior uveitis, and or vitritis. In contrast to immunocompetent patients, Herpes zoster ophthalmicus may occur at a younger age in immunosuppressed patients. And in immunosuppressed patients with herpes zoster ophthalmicus, persistent epithelial keratitis is more common. And in immunosuppressed patients, there is a greater likelihood of the VZV virus progressing to the posterior segment of the eye. Molluscum contagiosum is a viral infection with a pox virus and presents with a slightly elevated nodule with an umbilicated center. Immunocompetent patients usually have a single lesion, but in immunosuppressed patients, Molluscum contagiosum lesions are typically multiple and bilateral. Bacterial and fungal keratitis in HIV and AIDS may occur without a predisposing factor like trauma, and the keratitis is usually severe, rapidly progressing to perforation. Herpes simplex keratitis in HIV/AIDS presents with multiple peripheral dendrites. Peripheral dendrites are very characteristic of HSV infection in immunosuppressed patients. And in immunosuppressed patients, herpetic dendritic keratitis has a prolonged course with frequent recurrences. Granulomatous conjunctivitis can occur in HIV patients and is typically due to tuberculosis or fungi. Thank you for listening.